This is white cataract, and after giving incision and making side port, I put vision blue. The important thing about this cataract is that this is a fairly young patient, and pre-assessment, the cataract, there is an area of capsular thickening, anterior capsular thickening, which during the surgery I could find out the exact extent. It looks like a wrinkled area, look like capsular fibrosis. I started the Rhexis as usual with its cystotome from the side port after putting the viscoelastic. I just had a feel before I punctured it, the capsule, and using a circular motion, I started the Rhexis. It's going fairly nice. Same circular direction until I reach the edge of the thickened capsule, fibrotic area. From here, I continued as yes. Now, this area, suddenly I felt that the capsule of Rhexis is going out. From now on, I took the Rhexis and push it toward the center. If I would continue in the same circular motion, the Rhexis will run out. As soon as I reach the edge of the fibrosis on the other side, I put again some viscoelastic, cleared the area from the air bubble, and now with the Rhexis forceps, try to again do the circular motion, but I noticed that it will go out. So again, pull the Rhexis towards the center of the eye, and you can see Rhexis completed. It took me almost 2 minutes because this is the most difficult part of this surgery. After little bit of hydrodissection, the phaco was done, and you can see fairly simple, quick, as the cataract is almost cheesy, very soft, and it was not difficult to remove. It's just an aspiration only. As you can see, even I did not use the other instrument, the second instrument, and the cataract came out quickly without any problem. Once the cataract is out, started irrigation aspiration of the cortex with Simcoe cannula. There is not much to remove, and I noticed some posterior capsular fibrosis as well, but I decided to leave it like that. So I will be able to implant the lens without any complications. I try to remove cortex whatever possible, and it even it's small amount of fiber and Waters can be left alone because this patient eventually will need yak capsulotomy. And then fill the bag and the AC with viscoelastic and implanted acris of 1 piece IOL in the bag. So the whole point of this uh, cataract is that this type of cataract, that in this we needed to have a large capsular axis because of the central capsular fibrosis, and due to that it was quite possible that the Rhexis would run out, which I detected very earlier and used the technique to pull the capsule towards the center to keep the Rhexis in a circular motion. And after completing the Rhexis, everything was straightforward. So the early detection of your Rhexis running out is very important. Once you do that, it will be much easier to control your Rhexis and complete your case without any problem. Finally, hydrodissection done and case is completed. We always check for the leak at the end. If you have any questions, please do ask in comments and I will try to answer your questions and queries.